Once again, it's a pleasure to be here. And I thank again Betty Chung and KAIST for the opportunity to speak to this group. So today I'll be talking about an overview of the South Korean healthcare system. And as I mentioned, it will be both the academic side, the business side, the political side, as well as some patient aspects to this. So I hope I'll be able to paint for you a rather broad picture of what is a very strong aspect of South Korea, actually. So we're going to answer a number of questions during the course of this hour or so. What is Korea most famous for? What are the different kinds of healthcare systems? What is the converging paradigm of healthcare? What is the basic organization of the Korean healthcare system? How did it get that way? How does it work? How is it paid for? What are the results? And how about the future? And I'll just start with an important motivating quote from Martin Luther King, a famous civil rights activist, of course, as many of you may know, in the United States. And he famously said, of all the forms of inequality, which of course is a big theme nowadays in the world, injustice in health is the most shocking and inhumane. So this is not just a technical discussion about healthcare, but I think it has implications even more broadly into social structures, culture, and basic humanity. So in terms of outline, we'll talk about healthcare systems, zoom in on the South Korean healthcare system, do a little inpatient tour, an outpatient tour, some of the challenges and the results. So this is not just going to be a propaganda, if you will, about how great it is. It is a very strong system, but there are, of course, challenges. A quick review of the results, and then some speculations and insights into the potential future. So let's first focus on healthcare systems. I'll ask a question to the participants. You can interrupt or you can do by chat room. What do you think is, in your mind, what is Korea most famous for? Anyone want to comment?
Plastic surgery.
Plastic surgery. Okay, that's a good answer. What else? Remember, this doesn't have to be about healthcare. We're thinking very broadly. Excuse me?
Technology.
Technology in general. What else? What's the big one? Education. All of you are being too academic, too technical. What happened to K-pop?
Entertainment. K-drama.
Entertainment, K-drama, exactly. K-pop, K-drama.
Confucianism.
What was it? What was that?
Confucius, too much impact of Confucianism.
Oh, Confucianism. They're famous for Confucianism. Okay. What other things do you think Korea is most famous for? Like when you think of Korea, branding, if you will.
Beauty.
Beauty, K-beauty.
Mm-hmm.
And one last answer.
Their food.
Their food, okay, K-food.
Especially the kimchi.
Kimchi. So let me just summarize. So I think when we look as, say, outsiders at Korea, we think about kimchi, we think about K-pop, we think of K-drama, the beauty and cosmetics area, technology, and so forth. And in fact, a lot of Koreans would also agree when they imagine their reputation outside, they will say K-pop, K-drama, K-beauty, kimchi, and those sorts of things. I will argue in this presentation that what Korea is one of the most strengths of Korea is its healthcare system. And we've seen that at play in the COVID response, which I will not talk in detail, but nevertheless, most of you are familiar. But the Korean healthcare system is one of the things that Korea should be most famous for and is not necessarily famous for. It is what we would say an unrecognized strength. And that will be basically the take-home message that there's an amazing healthcare system, which we will explore today, and more people should know about it. And it may not be perfect. In fact, healthcare is very complex, and it's, nothing is going to be perfect. There are always trade-offs and balances, but it is quite good. And I have a lot of experience in healthcare systems in North America, in Europe, and Asia as well. So there's some comparative context. So this is a overview on one slide of comparative healthcare systems. And we can define the healthcare system. What's the position of the physician? What's the role of insurance, facility ownership, economic transfers? Where does the money come from? And some examples. Now, it looks like a complex chart, but we can do very simply map it in terms of, on the very left, it's all private. And on the very right, it's all public. So for example, an all private would be 19th century Western world, where healthcare is an item of personal consumption. The physician is basically a solo entrepreneur. There's no insurance. Everything is private, and the economic transfers are directly from the patient to the doctor, as opposed to a completely public system, socialized health system, where it's a completely state-provided public service. The physician, the doctor, or the clinicians are state employees. The insurance is all public. The facility ownership, the hospitals, the clinics are all public. And this is all indirect economic transfers. And I say this because there's a lot of debates around the world. A certain system is socialized medicine or not socialized medicine. This is the extreme level of socialized health service, and that would be the 20th century Soviet Union. Most real healthcare systems, if you will, current healthcare systems, fall in the middle. There's some mix of private and public. And in fact, if we look at healthcare systems around the world, I think it would be safe to say they are converging onto this model of national health insurance, where the physician might be a solo or a group. The insurance is public, but the facility ownership and the physicians are mostly private. So it's a mix of public and private. So examples are 20th century Sweden, France, Canada, Japan, and Korea is in this category. And I think this is very important to set in context. In other words, Korea is a very good healthcare system and very strong healthcare system, as we will talk about in the coming hour, but it's not the only model. In fact, a lot of models are converging onto what might be called a Korean system or other similar ones of a mixed public and private. So before I describe what it is, let me give you a little bit of history. So how did modern healthcare come to be? And this is important for some context. And this is a picture of the first operation with ether in Philadelphia. And Philadelphia was one of the first medical schools in the United States. Now, even though I'm an American, I'm speaking very US-centric right now for a very plain fact, is that after World War II, the post-war period, most medicine was modeled on the American model, the American system. And this has important implications. I'm not saying that the American system was the best or whatever, but I'm saying that in terms of structures, it was historically modeled on this concept of the American model of healthcare. And here's another picture. And there was one very American healthcare, and that was this post-war period was characterized by the baby boomers. So in the baby boomers, you can see the births increasing, and most of the population was basically very young. And what that meant is that the care of patients during that period of time dealt with very young patients. And so the focus of care was on acute care and taking care of people in the hospital, and then they leave the hospital and you take care of them and so forth. Why do I mention this? Because as you've probably heard, chronic medicine, chronic care is increasingly important. Diabetes, heart disease, et cetera, as populations age and so forth. So the historical standard of healthcare, which was developed during the young populations at the heyday of scientific medicine, is designed for acute care in the hospital. And that led to the academic medical system model that we see here. This is the Harvard system, and you have the academic acute care hospitals. And we're still grappling with how to take care of chronic care patients, even though the system was historically designed for acute care in terms of medical care provision. So that's an important backdrop, which we will return to in the coming slides. So now let's talk about the South Korean healthcare system. So this is a little bit complicated, but remember I was talking about the comparative healthcare systems. We can split it into the public side and the private side. And indeed, we have the public side here and the private side. So I'll go through this very quickly. The public side, the Ministry of Health and Welfare, the Health Insurance Review and Assessment Service, all feeds into the National Health Insurance Service. In the United States, we would call this a single payer system. So in other words, the health insurance system is public. Then if we look at the employer, the insured, the medical care institutions, this is all private. So the hospitals, the doctors are essentially private. Now, of course, there are some exceptions. There are some public clinics. Of course, the military doctors are going to be public and so forth. But in general, this is the split. So it's not socialized medicine. Socialized medicine would be everything is public. And it's, of course, not purely private because we have a strong government component. But this is not just a 50-50 split. They are split in terms of the insurance side and the provision side. Insurance is public and provision is private. And one reason why many comparative healthcare systems are converging to this model is that purely public and purely private have some significant limitations. When you have a purely public system like the Soviet Union, etc., and what some who are afraid of socialized medicine in the United States feel is that you lack the ability to have a local sensitivity, local care, decentralization, etc., basically principles of management and decentralization, innovation, and so forth, intersecting with ethical concerns, who determines who gets care, is it all centralized by some government body, etc. So when you make some parts private, you avoid that difficulty. On the other hand, when everything is private, then you have complications on insurance. So the concept of insurance, as you know, is to pool risk. But if you have hundreds of insurance companies, then what does it mean to pool the risk? You're basically, you might as well be uninsured and so forth. So a purely private system also has significant structural difficulties. So we mix them by having the insurance public and take advantage of the actuarial and financial benefits of a large pool of insured, which is what insurance is about, and the advantages of a private system that allows decentralization, localization, and personalization that, of course, is very important to the human activity of healthcare. And so this split is not random. It's not, 50-50. It is very logical, if you will, along these two dimensions. And that's what the South Korean healthcare system in principle is structured. And as I said, it's not totally unique. Other countries, like some in Europe and Japan and so forth, have similar systems. But there are, of course, differences, which I'll highlight. Now, some of the key points. Access. So access is very important in healthcare systems. We have in the United States not universal access. Some people have insurance, other people don't. There are some laws that say if you go to the hospital in the emergency room, they can't kick you out. But in principle, there are some limits to access, and a public insurance system allows for universal access. There's 100% coverage by mandatory national insurance system. So yes, on the insurance side, it is socialized, but you would not call the South Korean healthcare system a socialized healthcare system. And you essentially just walk in, you wait 15 to 30 minutes to see a doctor. Financing, you have what's called a low contribution, low benefit model. In other words, you don't have to pay a lot of money, insurance, but it doesn't pay 100% of everything. There are limits. So typically 80% is paid by the insurance, 20% by you. So if you have a huge bill, you can still end up paying a fair bit, not a huge amount, but a fair bit. But if you, for routine visits, it's extremely affordable. And that's the concept of financing. And then in terms of the providers, as I mentioned, 70% of the hospitals are private. So there's a system with academic medical centers, more smaller clinics, and then individualized clinics, private clinics. So that three-tier system is all under the insurance, but they have slightly different costs to encourage decentralization and people not going to all the academic centers, but going to their local doctor, which is, from a medical standpoint, actually more efficient. And then finally, the role of government is a very strong influence. Some challenges about doctors and their relationship to the government. We'll talk about these challenges. So what is the cost breakdown? Basically about 30% for consultation, about 40% for procedures, about 27% for pharmaceutical, and about 4% for medical devices. The administrative costs are very low in comparison to United States and some other healthcare systems. So it's a very efficient system. Now, this system did not just appear, and it has a very interesting history that's very important to keep in mind when it comes to development and perhaps other systems that want to replicate the South Korean model. So it started in 1977, where this concept of having insurance was mandated for large corporations employing more than 500 employees. This ended up with about 9% of the population being covered. So this is nowhere near universal. Then in 1979, soon after, government employees, public, private school teachers, corporate workplaces, more than 300 employees were then also required to get this insurance. Now, what's interesting is at this point, the insurance companies were still private. So there was a mandatory element, but it was still private. So it's almost like the Wild West. The South Korean healthcare system started from a completely private model, but they started to make some mandates while still keeping it private. So they said, if you're Samsung, your employees have to get the insurance and you have to make the contributions and so forth. And then in 1981, corporate workplaces of greater than 100 employees, and there was a pilot project for the self-employed, and this was a significant increase to about 30%. Now, why do I put this in highlight in yellow? Because most of you might be familiar with the concept of Obamacare in the United States. Now, Obamacare has a mandate for insurance, but the mandate is to get private insurers. In other words, you have a mandate in certain companies, and et cetera, and you have to get a private insurance. So this stage of the Korean healthcare system in 1981 is approximately the stage of the United States if it was to progress to this system. In other words, Korea, Obamacare was in 2009. Korea is about 30 years ahead of the United States in terms of this progression. Now, I'm not saying the United States will go down this path, but I just wanted to emphasize that this may seem very early, but actually this was a big step. And then after that, they expanded further and further. For example, dependent coverage, self-employed rural residents, self-employed urban residents, universal coverage. So over 90% was achieved by 1989. So that was the step-by-step approach. But at this point, what's interesting is that the insurance was still private. In other words, the mandate was for private insurance. And then in 2002, I believe it was, all of that private insurance was then nationalized into the national health insurance. The private insurance companies for healthcare, to put it bluntly, were put out of business. In other words, it was illegal to have, not illegal, I shouldn't say that. it basically general health insurance was not possible through private. Now you can do the supplemental to cover the co-payments, etc. So I misspoke when I said that about illegal, but it was basically for general health insurance, you had to be under the national health insurance. So the dozens of health insurance companies were all nationalized. Now, one reason why Obamacare is so difficult in the United States is that this progression implies that if you continue to expand the coverage in this way, perhaps the insurance companies will be put out of business. And of course, some people may not like that. So that's one reason why the whole Obamacare in the United States has become, so controversial, because it's seen as a step to socialized medicine. But as I mentioned, it's not socialized medicine. It is socialized on the insurance side, but in Korea, the private provision of care remains privately owned and not under the government. So that's an overview of the South Korean healthcare system in terms of structure, in terms of financing, in terms of history. Now, I'd like to give you a little inpatient tour from my own experience in the hospital. And this inpatient tour will take place at Seoul National University Bundang Hospital. KAIST does not have a hospital, so I apologize, Professor Chung, but since KAIST doesn't have a hospital, I can't show a KAIST example. But of course, this is one of the top medical centers in Korea. And I am a patient there in cardiology. And I'm going to show you how an appointment with the cardiologist works with these successive videos. Now, why do I show you this? For two reasons. One is that this gives you an example of how it works in a real way. And the second reason is that one of the other innovations, very important innovation in terms of Korean healthcare system, is the process innovation. So a lot of people think about healthcare innovation as gadgets or digital healthcare and so forth, but actually process innovation as opposed to product innovation is extremely important. And the Korean healthcare system has a lot of aspects of process innovation that are very significant. So let's start.
So it's now 11:47.
Can you hear?
And I'm entering the hospital.
Could you hear the video, by the way? Okay, so let's start it again. So the first one is I'm entering the hospital. 11:47.
So it's now 11:47. And I'm entering the hospital. And I will go check in.
Now, my camera angle is not always optimal because I wanted to preserve the confidentiality of other people. I didn't want to pick up other people by mistake. So if it's not perfectly clear, etc., that's the reason why.
So the way it works is I take my appointment slip, do the barcode. It will show my bill, the copay.
Forgot to ask about something about.
I put my card in. And then I get my card back, and it's going to print out and this will tell me where to go.
That's the co-payment.
it shows the receipt as well.
So then the next step,
So it's now 11:50.
11:50.
I scanned the barcode on the receipt,
대기표가 출력되었습니다.
and I'll get my number for the phlebotomy blood draw.
4 minutes later.
So I'm getting my blood tested. 11:54.
주먹 빼시고, 네, 힘 빼고 계실게요.
알겠습니다. $11.56. Finished the blood test. Now heading to urine sample.
So don't worry, I'm
Not
not
going to videotape that.
sample.
12 o'clock. Just dropped off the urine sample.
3 minutes
Heading
after.
to EKG. 안녕하십니까?
한국말 할줄 아세요?
예, 알아요. 1964년.
그래 로가님
예,
맞으신가요?
맞아요. 예.
저희 장비 때문에 통화는 끊어주셔야 되세요.
12:06. Finished the EKG. They didn't let the cell phone inside, of course. And now heading to X-ray, radiology. So I'm dressed now, waiting. This might be a little bit longer wait,
Might be a little.
but I think it should happen soon.
So 12:09.
It's now 12:14.
12:14.
Less than 20 minutes. I got the blood drawn. I registered. I got the blood drawn, urine sample, EKG, and X-ray. Those will be processed, and at 2:20 I'll have my follow-up appointment, and all the results will be available at that time. So now I'm going to have lunch.
This should actually be 12:14.
12:31. Finish lunch. Salmon bibimbap.
Should I get a
12,000 about
gelato as a reward?
$10.50. And by the way, they're very good at phlebotomy here. No hematoma. I think I'll hold on the gelato for now. I decided to get the gelato, chocolate mint. So to register for the appointment, I do the receipt,
1 o'clock.
and then I get a number here. So to record my blood pressure, I click on this receipt.
Automatically register.
And I stick my arm in the machine, and I press start. Okay, and then it's registered. So after my appointment, I got the slip,
Doctors,
and this is how I get my
all the tests are done.
prescription.
And I get the prescription by checking out. I do the barcode.
It's now printing. So there's the receipt and the prescription. In order to fill the prescription, I will use an app, take a picture of it, and it'll be automatically sent to the pharmacy. Once I arrive there in about 10-15 minutes, it will be ready for me.
So that's an inpatient visit. That's called process innovation. So now let's do a quick outpatient tour. This is visiting the orthopedic surgeon, and I don't have video, but I'll just go through it. This is on the 7th and 8th floors in Bundang. It's called Bone Plus with Dr. Kim Pil-soo. And this is the floor plan on this little office building. And basically it has a reception, it has waiting room, it has inpatient rooms, physical therapy, MRI, X-ray, CT, inpatient rooms, examination rooms, and ultrasound all on one floor. And then the operating rooms are on the 7th floor. So that's a pretty incredible sort of efficient arrangement. So it's not a big academic medical center. It's one of those small clinics. It's not small, of course, but it's considered a clinic. So let's talk about some of the challenges. First of all, medical fees are lower in Korea compared to other countries, and that leads to some distortions Korean doctors and hospitals make up by increasing the volume of medical care. And somebody at the beginning mentioned plastic surgery. And so many doctors say, well, we're not making enough money from the regular medicine, so let's go into new areas and drive, revenue and income that way. And one of the reasons for plastic surgery has been, many talented doctors and so forth who are dissatisfied with the medical fees being low, want to make, more money by serving that market. I'm not saying that's the only reason, but so if you're surprised, why is plastic surgery so big in Korea? There's both the supply side and the demand side. And so there's been an ecosystem around plastic surgery that in some sense is one consequence of these low medical fees. Another one is potential distortion. So some areas are uncovered like MRI, obviously like plastic surgery, but that has changed. There's now MRI is covered. This premium health checkup, which is more expensive. So that service has been offered. So the yearly healthcare checkup, which Koreans do very well, but that's an extra service. And of course, as I mentioned, plastic surgery, dermatologic care, and LASIK. And other ancillary services. So hospitals will have funeral halls, parking lots, restaurants, retail stores in order to increase that income. So how university hospitals survive on the ancillary services, such as the rents and parking lots and so forth. Of course, that provides a benefit. There's nice cafes and restaurants and so forth. As you saw, I had my bibimbap, etc. At the hospital. So another challenge is for profitization. The government is officially against it, but they're interested in medical tourism and the export of Korean medical system. So doctors are also against for profitization. The hospitals are mixed, but the Korean Hospital Association is so far for it. Again, these other areas of making up for the fees, civic groups are against for profitization and so forth. Now, another very interesting aspect to all this is telemedicine. By law, only doctor-to-doctor telemedicine is allowed. So actually, even though Korea is very advanced technologically, in terms of digital healthcare, it is actually quite behind many other countries. And that's because telemedicine is not allowed, which is very unusual. So this has changed somewhat after COVID-19, but digital healthcare is still surprisingly less advanced. So what is telemedicine? It's basically the ability to remotely care for patients. And the law says if you see a doctor, you have to see the doctor in person. And one of the reasons is limited utility in Korea. I mean, doctor consultation is inexpensive. It's very accessible. Every street corner has one of these clinics. People are concentrated. Access to care is excellent. So telemedicine is actually not so necessary as compared to geographically dispersed areas like the United States, Australia, Russia, Indonesia, and etc. As I mentioned, the government is trying to do this, but there's a lot of resistance from doctors, especially those clinic doctors like that orthopedic, because they're worried that all the patients will go to the more prestigious sounding, but not necessarily better, academic medical centers. The hospitals have been mixed, and civic groups are also mixed. So this is a challenging area of telemedicine, but I predict that because of COVID, we're going to see much more of this, and Korea will advance a lot in digital healthcare. So even though we have the smartphones and all that Internet of Things and IoT, etc., Korea is behind in digital healthcare, but it will probably start to catch up. So very quickly, what are some of the results? So South Korea is poised to lead the global life expectancy increase. So this is the highest life expectancy at birth. The red is South Korea. Other countries which are very high are France, Japan, Switzerland, but they are even behind Korea for both men and women. And what are the perinatal outcomes? This is the OECD average. So the population is a little bit lower. The crude birth rate is lower. The total fertility rate is lower. But if we look at the neonatal mortality rate, it's lower. The infant mortality rate is lower than the average. The perinatal mortality rate is less than the average. And the maternal mortality ratio is also less than the average. So Korea leads on all the perinatal statistics. But in terms of healthcare system ranking, it's surprising because the WHO ranks it overall at number 58. In terms of efficiency, it's number 4. So one of the reasons is people are not even really aware of how strong the system is. And as I mentioned at the beginning, you know, K-pop, K-drama, etc., but many people are not aware of the strength of the Korean healthcare system. So let me present a real case. So as I mentioned, I saw the cardiologist. So I actually had 2 years ago a heart attack, and I had never had one, and I had some chest pain, but it was going to my jaw. So I knew very clearly that that was not a normal, some chest pain, and given my medical background. So I went and I called the ambulance, and this is me going to the cath lab, and I got 2 stents. This is Dr. Shi-Hyuk Kang. And then less than 1 year later, I was running a marathon. I got the stents within 2 hours of onset of symptoms. And that's an incredibly fast, but not unusual for Korea. I mean, in the United States, you might be lucky if you have 4 hours or 3 hours. That would be considered very good. But I got the stents within 2 hours. So that's a pretty amazing example of the efficiency in the process innovation. Now, what was also interesting is I had a co-payment, but it was, you know, quite reasonable in the end for everything, including the ambulance and the whole inpatient stay. I was in the ICU for 1 day. My payment was about $2,000, which is not a small amount of money, but it's not ridiculously high as well. And that included the ambulance and everything. So it was a very seamless system. There was no special paperwork. There was no arguments with insurance companies, none of the particular games that are played in other healthcare systems. By the way, my time was 4 hours and 57 minutes, not very fast, but if you think about the context, I think that's a good outcome. So let's now talk about the future. And I'll talk about some global mega trends. So number 1 is populations are aging and increased chronic diseases. Remember I said at the outset that the model of healthcare is designed around acute diseases. This was the model developed by the paradigm of healthcare, which was the United States, in terms of academic healthcare and, you know, the best standards and so forth. But it was developed during a very different time, a time when people were young and diseases were acute and money was a lot and so forth. So we're seeing shifts in disease, but now we also see healthcare austerity, emerging markets, the locus of care is shifting. So overall, I would say that the biggest trend that everyone must keep in mind is the need for low-cost innovation. In other words, innovation that increases the efficiency of healthcare. Now, as I mentioned, populations are aging. So in both less developed and more developed countries, we're getting a crossover where we're getting more aged people than younger people. And that's even happening in less developed countries. Chronic diseases are increasing. This is the disability adjusted life years, which is not just mortality, but also disability here. Chronic diseases are increasing, it's highlighted in yellow. Cancer is actually not very high. Now, if you have this increasing utilization, but there's not enough money. So this is healthcare in blue, GDP in red. GDP is increasing, healthcare is increasing beyond that. This growth in core cost is clearly not sustainable. So low cost innovation is going to be very critical. So emerging markets define the future. If we look at Malaysia, India, Brazil, China, their costs per person are about an order of magnitude 10 times less than the developed world. So there's going to be a lot of growth, not just in population. This is orange, is the emerging, less developed countries, but also in the dollar amounts. And that means that emerging economies will drive a lot of healthcare innovation. The site of care is shifting to less expensive, to more localized, so self-care, more home care, being enabled by digital technologies. So high-cost medicine is increasingly obsolete. So this is a little bit of a joke slide, but we're going to run some tests mainly to pay for the machine. Maybe in the past that was not a joke, and now it's a serious problem. So in terms of future trends, we have digital healthcare, which involves data measurement, which involves data integration, data interpretation, and treatment, and integrating treatment with IT. And then artificial intelligence is an important part of it, with various applications such as AI-assisted robotic surgery, nursing, AI-assisted medical diagnosis, medical image analysis, drug discovery, as well as supporting functions that are very important. One of the interesting concepts of artificial intelligence is we go from explicit logic to implicit logic. What does that mean? As you know, artificial intelligence spits out a result based on big data analysis. What is the reason for the result? How can we explain the result? Well, we don't really know. So medicine, which has progressed for thousands of years based on explanations, whether they're right or wrong, that's another issue. Whereas in the AI era, we'll have medicine that progresses on the basis of just a computer result without explanation. That will lead to a lot of challenges going forward. And then, of course, pandemics. And they go in various phases. And of course, we've seen that with COVID. So I'm going to show a quick video here.
That's Star Trek Discovery, premiering this Sunday here on CBS. We are on the deck of the Enterprise known as the CBS Evening News. We asked Dr. John LaPook to tell us how well the Star Trek franchise has done over the years at predicting the future of medicine.
And I was able to put a scope in and biopsy the pancreas, which was unheard of 50 years ago.
Unless you were watching Star Trek, as NYU Langone's Dr. Mark Pachapin did when he was a boy.
To boldly go where no man has gone before.
Star Trek predicted the way you would scan someone is through a non-invasive way, without really touching them.
Star Trek's tricorder? Today we have CT scan, MRI, and ultrasound. What else has come true?
Where Captain Kirk would talk to someone on the flat screen TV, I can talk to a patient now, see their image, see their scans remotely.
Dr. McCoy's hypospray helped inspire needle-free injectors. The visor that let Geordi see? We now have glasses that beam light to a chip implanted in the retina. What about sickbay?
They'd get on the bed, and all of a sudden all the monitors would go on like the monitors we have here. And that has come true. We have wireless telemetry.
No, wait, don't tell me.
We consulted a specialist in Star Trek-style medicine. Bob Picardo played the emergency medical hologram on the Voyager series.
And then I would appear, and I would say, please state the nature of the medical emergency.
So do you think that eventually in the future, a computer algorithm could entirely replace a physician?
Ultimately, that artificial intelligence physician will be created from the personal experiences of a large group of doctors. So yes, I believe the day will come when you will be obsolete.
Until we reach that final frontier,
computer, end program.
I remain Dr. John LaPook, CBS News, New York.
So I actually disagree with that assessment. If you think there's if you think about it, there's actually a logical fallacy to that. I mean, obviously it's entertainment and it's an actor talking about his prediction for the future, the last segment, I disagree. They said that AI will capture the personal experiences of doctors, right? And make it into an AI algorithm. But think about it. If you do that, and then 100 years later, the doctors will have no personal experiences, how do you create the AI? So that's obviously not, going to happen. That doesn't mean that AI won't happen, but exactly how it's described there is not, really tenable. So I'll talk about some of these future trends, and such as what was touched upon in Star Trek, and more generally, and the paradigm shifts in medicine that are occurring. One is decentralization, as we talked about. Another is parallelization. When I showed you those slides about the American Harvard Medical School academic model, people went step by step as they analyzed patients. They would get the history, the physical, the lab tests, the x-rays, and so forth. We call that serial. But now with sensors all around, we call that parallelization. Another important paradigm is in that early system, you had the hospitals in the acute care with the baby boomers. So people were either good or well, or they were sick. So we have a divide between health and, between medicine and wellness. Whereas now with chronic diseases and older populations, everybody's a little bit sick, if you will. And so there isn't that sharp divide. And that is another big paradigm shift that's occurring. I talked already about the explicit to implicit logic, big data driven medicine, context enhanced data. So in the days of that Harvard Medical School in the 1950s and 1960s and so forth, you did things very scientifically. You would get a test and go on to the next test. And that test was kind of like a scientific experiment, if you will. You get a blood value, etc. But now we have all sorts of what we call context enhanced data. We get a blood pressure measurement or a blood test, but we have other data. The blood pressure measurement in the context of the time of day and the temperature and the air quality, all this comes together. So we have high multiple context data, not just individual data points. That's a big paradigm shift. And as I mentioned, it's a little bit related. Instead of episodic care, you go to the doctor and then you leave, you have pervasive care. We have smartwatches, we have glucose sensors, taking our measurements all the time, not just when we go to the hospital or the doctor's office. The concept of population and individuals converging in the data, the model of epidemiology is we do a study on populations, a clinical trial, we test a vaccine, and then we go and try them on individuals. But now, if we're getting data from individuals, such as Google gets when you search on the web, in real time, in a sense, individual care can result in population epidemiologic care in real time. We've seen that almost with COVID. Not quite there yet, but with data about transmission and testing results, we see at an instant what's happening with the virus in a very short period of time, instead of waiting for a 2-year study and then publication and then see what happens in the individuals, etc. We're getting closer and closer to real-time analysis. And then finally, empowering primary care and the fusion between diagnosis and convergence, diagnosis and therapeutics. So we've asked a few questions. What is Korea famous for? As I've argued, the healthcare system, I think, is one area that Korea should be very famous for, underappreciated. What are the different kinds of healthcare systems? We talked about private and public. What is the converging paradigm of healthcare? Public on the insurance side, private on the care side. What is the basic organization of the Korean healthcare system, which we described? How did it get the way? The progressive expansion of the eligibility, and then the very quick nationalization of the insurance. How does it work? How is it paid for? What are the results? And how about the future? So thank you. Please take care, of course. And I'm on LinkedIn, and you can connect with me there, and I'm happy to keep in touch and open for questions now.
And so, Dr. Gurel, you and I had talked over the phone multiple times regarding this little mini session. And as you know, there